Ladies and gentlemen, welcome to Dental XP. My name is Dr. Aldo Leopardi, and it is my pleasure to present to you this topic of implant abutments, pre-contoured components. Up until recently, our abutment choices have been conventional stock abutments, pre-manufactured, and customized abutments. Customized abutments could either be laboratory cast or computer milled. There are advantages with conventional stock abutments, essentially availability. They are generally lower cost than custom abutments when utilized correctly. They have a milled interface providing a consistent fit and also strength. But ladies and gentlemen, there are disadvantages. And these disadvantages particularly pertain to the aesthetic zone, some of which involve lack of emergence profile under the tissue margin. Following preparation of these abutments, often the margin of the restoration needs to be placed considerably subgingival. So the emergence profile subgingival is not generated by the abutment, it's generated by the crown. The problem with this is cementation. If the cement margin is placed subgingival in order to develop emergence profile, and it's placed subgingival beyond 1.5 to 2 millimeters, it could be almost impossible for the clinician to remove that cement. Consequently, most anterior restorations and the abutments associated with these restorations, the abutment is generated with the custom technique, the UCLA technique. In this way, the dental ceramist can generate an abutment, develop an emergence profile subgingivally, so that as the crown is cemented, the margins are only placed slightly subgingival, with all of the emergence profile and the soft tissue being supported by the abutment itself and not by the restoration, providing ideal aesthetics, simplified procedures, and ultimately an excellent functional and cosmetic result. The slides you see in front of you just go through that process of the UCLA technique on the lower premolar area. In the anterior zone, this is obviously where the UCLA technique is most advantageous, because the emergence profile in the anterior zone dictates the gingival contours, the rise and fall of the soft tissue. In this example for this patient, she has bridge work from 1.3 to 2.3. We're going to replace missing teeth number 6, numbers 9 and number 11 with implants, and teeth number 7, number 8 and number 10 with regular porcelain fused metal crowns. The objective is these restorations need to be indiscernible from each other, and utilizing a customized abutment technique we were able to achieve this result. But there are other ways to generate customized abutments, and these can essentially be generated via the computer and milled by a machine, such as the Atlantis abutment. More recently, implant companies have stepped up to the plate and have introduced components that have pre-contoured features, that have emergence profile built into the components, all of the components, and in particular the abutments. On top of this, not only do they have these pre-contoured features subgingivally, but the marginal designs follow gingival contours. They have a three-dimensional component to them. Consequently, the laboratory doesn't need to grind these abutments as much as the conventional stock abutments. If you have a look at the schematic, you'll notice that with this particular implant company, there's a rise and fall to the marginal design. The facial margin is closer to the implant platform, which is where it needs to be in order to hide the restorative margin in the aesthetic zone. However, the lingual margin is much higher, where the aesthetic zone is not an issue, and however, accessibility to excess cement is. And if you look interproximally, there's also a rise and fall, simulating the interproximal rise and fall of the coal of the soft tissue. So this area supports the soft tissue interproximally, providing support and providing a biocompatible surface for the soft tissue. Other advantages is that with most manufacturers, these components come in straight and angled abutments. They have different marginal heights, different profiles, different contours to simulate that natural emergence profile below the soft tissue. And they come in different materials, titanium and ceramic, all of which have documented biocompatibility. I'd like to share with you this example. 2 lateral incisors. This is a non-segmented, pre-contoured stock ceramic screw retained restoration. The company is Lifecore Dental. It's an all-ceramic zirconium abutment. And Johnny Nicanoni, my ceramist, has baked porcelain directly to the abutment. Access to the screw is toward the lingual. Consequently, we have a completely screw-retained restoration. In this young man, his name is Stuart, he has a ceramic restoration on 6, a ceramic restoration on 8, tooth borne, ceramic restoration on 9, ceramic restoration on 11, tooth-borne, and 7 and 10 are implant retained restorations, ceramic also. Because we have ceramic against ceramic, we lack the challenges that we find when we have dissimilar materials next to each other. One of the challenges of having dissimilar materials, for instance, a ceramic restoration against a porcelain fused to metal restoration, is a phenomenon called metamerism, where under different lighting conditions you have a different optical effect from the restoration. You can actually discern the difference between the two restorations, and obviously that's not what our objective is. Our objective is to have it indiscernible. So the advantage for Stuart here, where he has all ceramic restorations on his adjacent teeth and an all ceramic implant crown, the materials are essentially similar, so metamerism is less of a problem. Here's a view of Stuart's x-rays, indicating excellent implant placement, also showing us that the reason he has papilla is because of the proximal peak of bone on adjacent teeth, not the implant. And now a superimposition of those x-rays on the tooth. Other advantages: you can perform cement retained or screw retained restorations. Here's an example of a cement retained restoration on a pre-contoured implant component from Lifecore Dental. The implant component was prepped by the laboratory, a crown fabricated on that prepped implant component, so essentially it's utilised as a die, and then through the clinical procedures intraorally, the intaglio fit, the interproximals and the occlusions adjusted, and the crown is cemented on with definitive cement by myself. However, they do not need to be cement retained. The titanium components can be also tapped from the lingual and held in place with a lingual set screw, as in this example. So this way you are able to afford the patient a retrievable restoration if needed and still provide the patient with good aesthetics. Also, there's another technique possible with these components for screw retention. If access to the actual screw is toward the lingual, you can provide a patient a conventional screw retained restoration utilizing pre-contoured components. A crown can be fabricated with a lingual chamber, lingual access. The crown is cemented onto the abutment either by the laboratory technician or yourself with Panavia cement, then removed from the cast or removed from the patient's mouth, unscrewed. The margins can then be finished extraorally in your hands, and you'll know then, you're guaranteed that you have no excess margins. You're also guaranteed you have no areas for ingress for bacteria. The restoration can then be screwed back into the patient's mouth. So essentially you have melded every single possible technique for restoration, cement and screw retain, and also utilizing the advantages of pre-contoured components. All those advantages I talked about earlier. In the posterior zone, these restorations can be quite predictable, utilizing pre-contoured components, especially in the premolar areas, as in this case. If you look at the emergence profile of the prep abutment, it simulates ideally what we're trying to achieve in this region of the mouth. Pre-contoured stock abutments can also be utilized when splinting multiple restorations. Let me show you this example. In this patient of mine, this patient has presented with significant posterior atrophy of the maxillary posterior ridges and the mandibular posterior ridges. My surgeon, Dr. Ollie Jensen, performed grafting in the maxilla in the form of a sinus graft and split ridge technique and implant placement in the mandibular posterior regions. Multiple implants. The crown to implant ratio is not ideal, and the areas are grafted regions. Consequently, as a restorative doctor, I would like to take advantage of splinting these restorations for biomechanical reasons, to be able to distribute the stresses more evenly and give the patient some biomechanical advantage to the restoration. The restoration is going to be cemented on also. So the abutments are prepped, the restorations are adjusted, fitted, finished and cemented in place, providing the patient aesthetics and posterior support at the same time. These are the x-rays, indicating good contour, gradual emergence profile developed directly from the implant platform, utilizing these pre-contoured components. A significant advantage with pre-contoured components is that the manufacturer can provide us, the clinician, healing abutments with the same contour as provisional abutments, with the same contour as impression post, also with similar emergence profiles as definitive abutments. So from the beginning of the restorative procedure to the end, Consequently, from the beginning of the restorative process to the end, we're utilising components that have the same contour. It facilitates the clinical process significantly. Here's an example of an impression post and X-ray and a definitive restoration. The contours are the same. Implant companies have now introduced one-piece implants that also incorporate the contoured abutment with their one-piece design, both straight and angled. So now we are combining the advantages of the actual contoured abutment with the one-piece concept. Obviously there's going to be a limited application for this implant design, but we do have it in our armamentarium if needed. Ladies and gentlemen, there are disadvantages, particularly when implants are divergent and there are multiple implants. Significant adjustment and grinding is required in these situations. If that is the case, if significant grinding is required, then the custom abutment is the abutment of choice. Here's an example. The abutment on the left is a titanium contoured abutment that's been prepared by the laboratory. The abutment on the right is a custom gold abutment fabricated by the same dental technician. If you look at the X-rays, the contours are identical. You can tell the materials are different, but the contours are identical. One of the main disadvantages with this system relates to the surgical placement of the actual implant. Implants are generally indexed. They either have internal hex or external hex, so 6 surfaces, 6 positions to place the implant, or internal lobes, 3 lobes or 6 lobes. The lobe of the implant or the flat of the hex, whether it be internal or external, needs to be positioned tangent to the curvature of the arch. If not, these contoured components cannot be utilized as designed. Here's a clinical example. This is a small diameter implant. It's in a lateral incisor area, and I have a 3mm cuff angled pre-contoured abutment. And I've placed it on one of the anterior lobes. And if you notice, the midfacial margin is facing towards the distal. Well, that's not going to work. So let's try the other lobe. Now, the midfacial margin is facing towards the mesial. Consequently, the lobe of the implant is obviously not tangent to the midfacial. What's tangent to the midfacial is a point between 2 lobes. This is a typodont example on the screen showing the correct implant position, and my clinical example from previous showing the incorrect lobe position. Ladies and gentlemen, allow me to introduce to you one of my patients. Her name is Jenna, and she's congenitally missing teeth 7 and 10. This is Jenna in January of 2006. She just recently had her orthodontics completed, and she is the age of 17 years. This is Jenna following uncovery of 2 small diameter internal connected dental implants. And she's presented to my office, and what I'm going to do for Jenna is take some implant level impressions. The whole purpose of taking implant level impressions is for me to be able to generate for her customized provisional restorations. The slide on the right shows you screw-retained provisional restorations, and these have been fabricated utilizing provisional components from the manufacturer. You notice they're screw-retained. You'll also notice that the access chamber is toward the facial. The access chamber is going to be sealed with composite resin, so it's not a problem. I'd like to share with you a technique of capturing the emergence profile after fabricating these restorations in the laboratory. Quite often the emergence profile that these restorations have mimic very accurately the definitive profile for the definitive restoration. Consequently, prior to delivering these, I inject polyvinyl siloxane around the provisional restorations on the master cast. If you look at the slide to the right, the provisionals have been removed, and you can see in 3-dimensional form the emergence profile captured in polyvinyl siloxane. The advantage of capturing this information is that impression posts can be modified in the laboratory, and this 3-dimensional component can be captured utilizing GC pattern resin, as you can see in the slides in front of you. This is Jenna 10 days post-implant uncovery, and the restorations are delivered. The access chambers are sealed with cotton pellets, Thermite-N, and some A1 composite resin. Now, Jenna lives in Iowa. She doesn't live in Denver where I practice, and she goes to school in Iowa. So I am unable to see her. She's been away for now 6 months, and she returns from college for me to continue with her treatment. The biggest advantage for providing, one of the biggest advantages with screw-retained provisionals for Jenna is that the possibility of a problem occurring while she's away from Denver is much lower, And also there's no cement to be concerned with. There's no excess cement to worry about a possible soft tissue infection or complication. As you can see from the slides, her soft tissues have now matured. It is 6 months post provisional insertion. And we're ready to proceed with the next step. The next step is to take an impression. The access chambers are sealed with cotton pellets, thermite and composite resin. And this is Jenna 10 days post-implant recovery with the restorations delivered. And now Jenna 6 months post-implant recovery. During that period of time, Jenna was in college at the University of Iowa. And one of the advantages of having a screw-retained restoration is that the chances of these restorations coming loose are much lower than if they were cemented on. And another big advantage to the screw retention versus cement-retained provisional restoration is that I don't have to worry if I inadvertently left some excess cement behind. I don't have to worry about any soft tissue interactions or complications. And probably more importantly, I believe, is if these did come loose, let's say they were cemented on and they came off, it'll be more difficult for Jenna to be taken care of away from Denver, and so consequently there's less stress involved. And as you can see, they did not come loose. This is 6 months later, and now it's time to take impressions. This is a picture of Jenna's provisional restorations removed, and what it shows is the emergence profile duplicated in soft tissue as a result of having pre-contoured provisional restorations and a triangular, healthy, emerging soft tissue. The impression posts that I customized earlier on are now delivered and an open tray impression taken. Most implant companies provide the clinician trial abutments, and the trial abutments are actually very important. If you look at the slide to the left, there are plastic trial components that have different marginal heights and different angulation. By utilizing these trial components, we can select and purchase the appropriate component from the manufacturer. For example, the trial components that you see in front of you are angled abutments that have a 2mm cuff. Consequently, I'm going to order 2mm cuff angled titanium contoured abutments. These are the abutments on the master cast, post-preparation by my technician. If you look at the lateral view, you can see the rise and fall of the margin in 3 dimensions. Here's a mirror view. And here's a view of the restoration on the abutment, facial, interproximal, and also lingual view. These are the definitive crowns 3 months post-delivery in Jenna's mouth, 7 and 10 region. Let's have a look at the x-rays. And these x-rays are superimposed over Jenna's teeth to give you a better indication of vertical positioning of the implant, interproximal peaks of bone, or providing us with a definitive cosmetic result. Now here's a close-up view of 7 and 10, and again superimposition of the radiographs. A lingual view, and the lingual view shows lingual set screws. And now a definitive view of her smile. This is Jenna prior to treatment, and now Jenna post-treatment. Of course, all of this cannot be possible without support from our dental technician. And I would like to give credit where credit is due. Johnny Nicanoni from Dental Vita Laboratory in Adelaide, Australia, is a ceramist on this case, and he did a wonderful job. Ladies and gentlemen, it was my pleasure to present this program to you.